Out Loud, a podcast by Chasing the Rainbows with your host, Bernice Quisenberry.
On this week's podcast episode, we are discussing the beginning of infertility challenges, and we are having this discussion with OBGYN Costa Susu, who has been practicing for 29 years as an OBGYN doctor since 1994. Thank you so much, Costa, for joining us.
Thank you.
Yes, and just real quick before we start diving into this topic, I just want to do a quick disclaimer. We are not giving out medical advice. We are not medically treating any person, medically diagnosing any person, providing second opinions, virtual consults through our podcast. This segment is just to give some peace to our listeners who may or may not be struggling with some questions. And we're just opening the dialogue and the ability to not feel like we're silenced or being judged around these topics. And we are promoting awareness and actual feelings that occur during our losses, if it's fertility, if it's miscarriage, stillbirth, or infant loss. And it's for a safe space for us to talk about these thoughts and feelings openly. And for medical advice or treatment or diagnosis, please consult your primary care physician or obstetrician. Our intention is solely to help survivors, process and their traumatic losses. So thank you so much, Costa, for being here. Like I said, we have had numerous conversations with survivors, and we are so grateful that people are finding us on our Cried Out Loud podcast website because, there are some topics that survivors want to hear. And one of them is starting to know or think that maybe a couple is going through some infertility struggles. So, with that, it's just nice to have someone to talk to because, you usually start with your OB, at least, we were dealing with secondary infertility. So when a survivor is realizing it's not as easy to get pregnant like they thought and it's not happening, what do you recommend that the couple does first?
Well, the first thing I think is important is to make a consultation with your OBGYN. And during that conversation, I believe a lot of things are going to be brought up. For example, how long have you been trying for? Ideally, it depends on the age of the patient, but we always say that we don't really like to intervene until you've been trying for at least 6 to 12 months, although that, of course, can be different for different people. We want to know how often your periods come, because having a regular menstrual period every, let's say, 28 days is going to at least tell us that maybe you are ovulating. If you're not having a regular menstrual period, then it may be time to look at other possible causes for your menstrual periods not to be regular. So we draw some blood work, check and see if you have an underactive or overactive thyroid gland. Look at the prolactin level, which can rarely be elevated, but it can sometimes, and that can, of course, cause the periods to be irregular. We want to make sure, let's say if a patient is a little bit on the older side, let's say in her early 40s, want to make sure that we draw an FSH level on her, although we can do that on anybody. And the FSH level, I like to have them draw it on the third day after their period begins, because if the FSH level is on the lower side, not too low, but lower side, under 10, then at least, we say that she's able to manufacture adequate amount of eggs, oocytes in her ovaries to respond to the FSH. FSH, by the way, is follicle stimulating hormone, and it's produced by the pituitary gland, and it's supposed to stimulate the ovaries to, help in the maturation of the eggs. And at the same time, production of estrogen, which then will go back to the pituitary gland and tell the pituitary gland, stop producing any more FSH. We got it. We're okay now. And so, for example, if the FSH is very high, then that might indicate potentially that a person is approaching menopause. Um, you know, After the blood tests are done, we could simultaneously do other things, but sometimes we want to make sure that they're the three important issues when it comes to infertility are male factor, female factor, and then whether or not the fallopian tubes are functional. So we can do a couple of tests there. We can do an ultrasound to verify if the cavity of the uterus is normal. If there are fibroids inside the cavity of the uterus, that would potentially result in a loss. Not necessarily an infertility, but a loss. We can do an HSG, which stands for hysterosalpingogram, which is a dye test where we inject some dye into the uterus through the vagina, and the dye is supposed to be released out the fallopian tubes, which will indicate that the fallopian tubes are open. And of course, for the male factor, we generally will want to have his semen tested because it's not always the problem isn't always with the woman. It can also be with the man as well. So we want to see that he's got good motility, he's got good numbers, they're normal appearing, sperm and so forth. And I think that in of itself is, as an OBGYN, a regular OBGYN like myself, would be the full extent of our workup. Now, there are, of course, cases where we can do a day 21 progesterone level to determine if, let's say, they ovulated that particular cycle. We can do that on somebody who has regular cycles because we want to make sure that, they have a period every month, but are they really ovulating? And so that would be a day 21 progesterone level. I've started patients on Clomid. I've started them on letrozole. Those are the two medications for those who have had trouble trying to conceive or who've had irregular menstrual cycles related, let's say, to PCOS or other problems. And that might kick in their ability to ovulate and then just go from there. But I think once that has been exhausted, I truly believe that it is time to refer them out to an infertility specialist, because at that point they will want to talk to them about other options, such as in vitro, ICSI, donor egg, donor sperm, the whole slew of things that are possible for infertility specialists that we as OBGYNs really can't do because it's time consuming and it's a profession all on its own. We can't,
Absolutely.
just do that.
Yeah, no, that makes complete sense too, Costa. Yeah, I appreciate that. And, just to back up a little bit, when you're saying the 6 to 12 months of tracking or whatever, their OB recommends, when you're talking about the tracking and all of that, what does that kind of look like for both the male and the female?
Well, I think, first of all, if a person, I shouldn't say person because it's a couple, obviously.
Yeah.
But if a couple has been trying unprotected sex, has been trying, and let's say they have utilized some of the things that are out there. I know there are apps. I don't really like the apps. An ovulation kit serves them just as easily.
Yes.
You do a quick ovulation kit, you pee on the thing from day 10, and once that is positive, then you should have relations within the next, say, day or day and a half to 2 days. Okay, and if you've been doing that, you don't have to do the ovulation kit every single month. If you do it once, that'll tell you exactly when especially if you're having irregular menstrual cycles, it'll tell you exactly when you should be ovulating. So let's say you have sexual relations around that time period every month, and it's been going on for the last 6 months or so, and nothing is happening, then I would say it's probably a good time to consult with your OBGYN and say, hey, what's going on? I'm not able to conceive. Is there something else going on that you might help me figure out?
Right, and you're so right. We utilized one of those kits at home, and I was tracking all of my levels because there was to make sure that I understood when my cycle was happening. Now I was one that was dealing with irregular cycles, so for me, for 6 months, having to track and kind of keep track of it, it was very overwhelming. I almost felt like I was part of the medical team at that point because you're doing and then doing your basal temperature and doing all these different things to see, and then also just looking at all various things. And it's just interesting because, like I said, I never thought that I would be in that position where I would have to track, and then during ovulation, then that's when we have to try, because it kind of takes away from the excitement of trying and things like that, because then it does start to become more medical,
Hmm.
looking at it that way.
Yeah, and I totally agree. I mean, when you're doing it where, as I said before, you're tracking when your ovulation is going to be, and you're doing that, it's almost like you're putting yourself under a microscope. Ideally, when a person is when two people are having relations, you want them to have it for the excitement of having relations, but at the same time, you are, of course, looking to try to conceive. So you're basically, it's almost like a duty or a job. But as far as basal body temperature, now with the basal body temperature, the temperature goes up after you ovulate. So that's kind of an after the fact. So when do you want to test yourself to see whether or not you ovulate is by the ovulation kit. Now, in somebody who has irregular cycles, they may not have a positive ovulation kit because they didn't probably or will not ovulate at that month or that time. And so, in those cases, especially if your cycles are just all over the place, you don't have to wait the 6 to 12 months because it's probably good enough time to get yourself in, especially if this has been an ongoing problem. Now, people can have irregular periods from all sorts of things. They can have them from stress. They can have them from weight loss, weight gain, anorexia. Long distance runners have like no periods for a certain period of time.
Oh yeah.
But I'm talking about somebody who, let's say, would ideally be considered as a PCOS patient, polycystic ovarian syndrome patient. That's the kind of patient that's probably had it more than likely ever since she started having periods. Her periods are just never on a monthly basis. They're all over the place. Sometimes you have to take a medicine like progesterone to bring a period on. And those patients, over the course of time, could be potentially at risk for other issues. But those are the patients that I think definitely would need to come in sooner than later. It's those patients who have a regular menstrual cycle, who've conceived once before, who've had no issues, no prior infections, no prior surgeries, no prior endometriosis, nothing that would suggest a full workup is really necessary at this time. Those are the patients that can wait 6 to 12 months because the belief is that the ability to conceive, it takes a while. It's not magic, and it may take a while, and hopefully over the next 6 to 12 months it will happen.
Yeah, absolutely. And looking at it, um, it's like, you know, when you are starting the process and you're looking at all of it, like for me, it was said that, I already did have a healthy pregnancy, already did get pregnant. So there shouldn't be, right, the shouldn'ts be any issues. But through that, though, I've had surgeries for cysts and fibroids, which cause scar tissue, which then, leads to different things. And it really did cause, secondary infertility. So I think, like for me at first, like it was really hard to even recognize that maybe we are having fertility struggles from, those procedures because I didn't know. I didn't know, like, because when you're looking at it, like, we're just trying to handle the problem, right? We're just trying to handle the fibroid and the cyst at that time. where I wasn't looking at all the other things that could cause it because that was directly what was being presented. I think it's hard to sometimes wrap your head around, okay, is this really happening, or is this really, something that we're dealing with?
Oh, absolutely. I mean, it again, it goes by the history of the patient and their ability to conceive before. Whether you conceive and have a miscarriage, it's the fact that you were able to conceive successfully. That's the thing. At least will signify that if it's the same couple and they're still young enough, they shouldn't have a hard time conceiving again, especially given regular menstrual cycles and nothing else has changed. But in your case, you've had surgeries, which you're right, you can get scar tissue, fibroids. Depending on where the fibroids are, and I don't think we need to get in personal, but
Yeah.
it depends on where they are, will depend on whether or not that could potentially cause you problems if they're in the cavity of the uterus versus if they're on the outside. If they're on the outside, they're not going to really make a big deal, other than, of course, they continue to grow during pregnancy and can cause some pressure. But other than that, they shouldn't lead to an infertility issue or an early loss. But if they are obstructing the fallopian tubes, yes, they could make it potentially a problem for a patient to be able to conceive out of just one tube now, because the other tube is compromised from the fibroid.
Right. And then also, too, this brings up, a different point and something that, survivors have talked about. They've gone through a few, like they're able to get pregnant with their partner, but then, they're having miscarriages. And, that sometimes can lead to, different things that are happening that they can't see or know, and then having to seek, a fertility specialist or things like that to help them to be able to go to full term. And like, what does that kind of look like too in that regard when someone comes to you and with that testing?
Yeah, I think well, the two types of practitioners aside from the regular OBGYN that are out there for helping people are going to be the infertility specialist that's going to help you get to conceive, and then you have your maternal fetal medicine specialist who, in situations where if you've had trouble carrying a pregnancy or have had issues such as an early loss or whatever, to help you determine, or at least help work up the process of somebody who's had those multiple uh, losses or multiple issues, medical issues that might potentially cause them a recurrence of that problem. But right now, like I said before, if you've had regular menstrual cycles and no other issues, I would say wait the 6 to 12 months and then have a conversation with your OBGYN. Make sure, of course, again, as we said in the previous episode, make sure that you are ideally able to conceive. Make sure that whatever diseases you have are under control with the right medications. Make sure that the medications are safe in pregnancy. Make sure that you're not smoking. Make sure that alcohol intake is limited and would need to be stopped once you do conceive. Make sure that hopefully you are at close enough to your ideal body weight, because obesity can be potentially a problem for conceiving, but it also can cause diseases such as gestational diabetes and large babies and so forth. So those are things that you also have to understand as a patient, that you need to verify that you have gotten all those under control before you seek medical advice.
Well, and I think that's just great to talk about because, what are things that like survivors can do on their end besides just, tracking, but looking at their lifestyle, looking at things that they can maybe change or, do when they are trying to conceive, to try to help in any way, in a positive way, and I think that's important to talk about and share too.
Yeah, yeah,
Looking
it
at it
is.
holistically. Yeah.
It is. It is. And it's always important, and I can never say it often enough, but it's always important that a couple doesn't try to conceive too soon after they have had a loss, because you do want to have that adequate amount of time to be able to mourn the loss, and and not try to just go ahead and conceive right away, because in the potential, um, you know you're basically masking, and it's not a good idea. I used to tell patients way in the beginning, when I used to when I started practicing, after they had, let's say, an early miscarriage, I used to tell them, wait three cycles or 3 months. There's no rhyme or reason for that. I think a lot of that was you carry that with you, because as of course a doctor in training, that's what other people said, so you say it. But all that really does is it just says, hey, wait the 3 months so you can complete your you know um, mourning and so forth, before you try again. You can try again as early as when you start ovulating, right after a miscarriage. The only thing is, it's probably not a good idea to try so soon right after a loss.
Absolutely, no, and agreed, yeah. Well, and like you said too, like going to your medical provider, talking to them about it, and seeing, um, all around it and all of that too. Um,
Yep.
and how would, when they do go in, right, to their OB, and they're talking to them like fertility, it's constant losses, because every month you're getting reminded, once your cycle comes and you're getting your menstrual cycle, that here you are, no baby, again, and you're trying and trying and trying, and it gets so frustrating. And it's just constant letdowns almost,
Hmm.
until you are able, if you are, or if not, going to the next level. And
Yep.
and how do you work through that with your patients and get them to a point that they feel comfortable then seeking a fertility specialist, and if that's the route that they go.
Yeah, I mean, a lot of the time, I would love to be able to work with my patients and get them to conceive through us, because let's be honest, infertility is not covered by insurance.
Right.
Um, but we can work around that. And somebody who has irregular cycles, we can say she has irregular cycles, that's covered by insurance. Then we can put them on a, let's say, clomiphene citrate, which is the generic of Clomid. That can be worked up in insurance, and so on and so forth. But when you start taking them through an infertility specialist, you know um, I don't have anything against infertility specialists. I wanted to be an infertility specialist at one point in my life, but the infertility specialist will want upfront money. Okay, they will want you to be in their office or ultrasound department, or where they draw blood from you, almost on a daily basis, because they want to verify what time, the timing of the for example, when the egg has grown to a certain level, at what time they should consider insemination, and artificial insemination, or in vitro, and so forth. So those are almost like being put under the microscope. And then there's no guarantee, because even at the best of places, they're going to tell you we have a success rate of maybe 40% or 50%, and even with your own eggs. Okay, and then let's say you have poor egg quality, for example. Maybe you're a little older and so forth, and you just don't have adequate number of eggs. Then they talk about getting a donor eggs, and those are expensive as well, because then you have to go out to the site where they have those patients who are willing to donate their eggs, and you pay them directly. And it's a lot of things, not to mention cost of ultrasounds, the cost of medications, the cost of the shots that you have to get, the cost of the blood work that you have to do, the cost of the infertility specialist. In vitro is done under some form of sedation, so cost of anesthesia, special room that you have to have it done in. So there's a lot of, if some people will quote you 40, 50, $60,000, that's probably close to how much it would cost, and that's again out of pocket. And that's the problem. There are very few places. I don't think there are any places that accept insurance. Maybe Medicaid, but those are the universities. But I'm talking about like private infertility specialists will generally not be able to take insurance because insurance doesn't cover it.
I know we actually talked about in one of our podcasts about how there's only, I think like 19 states out there that cover infertility and then the rest don't. And, it is very expensive and it's something, but obviously, when you get to that point of, you've exhausted all of your avenues and you want to have a baby so badly, and you want to become a parent, it's like, okay, we have to do this. And then you have to find the means. And it just adds another layer of stress, financial strain and things like that on the
Yep.
couple. But I mean, obviously, it's worth it if that's the route to go down because there's nothing else
Yep.
to do. And you
Yeah.
come to that crossroad, and I think having those conversations with your OB, right, and discussing, okay, when does this look like I have to go down this route? Or, we tried everything here medically. Now we have, this is your next avenue. And I think just educating, the couple on that and knowing what to expect is so important. So they are armored, and they're educated and advocate for themselves. And then they know going into it, right, what to expect. It's so true.
Exactly.
Yeah.
Exactly. We have those conversations with our patients because we will be upfront with them. We're not gonna sugarcoat it. We're gonna tell them it's not an easy venture. Do you have that kind of money? And I've had conversations where I've told patients, look, there are kids out there that need adopting. Have you considered potentially putting yourself out there for that? It may not be as costly, and it's still just as rewarding potentially. But yes, having your own baby is important. But sometimes, you know, um, like I said, the percentages are not 100% that you will conceive through infertility.
Well, and I think
Um,
you're right too. Each couple is different, and it's like, okay, well, are you looking for, being pregnant with your own baby? Are you looking for a baby? Are you looking for a child? Are you looking, what does this look like for you? And I think, like for us, it was like so, it was like a whirlwind. Like, oh my goodness, we're having struggles getting pregnant. And we're dealing with all of these things, and and having to look and evaluate things that we never thought that we would have to before. And then
mhm.
hearing it, and then, like I said, educating ourselves to know, okay, what's the best route for us? Because each person and couple is so different with, what direction they want to go in. And it's so
Exactly.
true. Yeah.
Exactly.
Yeah. Oh, well, thank you so much, Costa, for being on here and,
Well,
describing the beginning stages of what it looks like if a couple feels like, they might be having some fertility challenges and, starting that dialogue with their OB and, what they can kind of like see and, what happens, in the OB world before, fertility specialists and things like that. So we just appreciate you so much getting on here and, starting that.
well, thank you for having me.
Absolutely. So, thank you so much for survivors for tuning in. We look forward to you tuning in next week as well. If you guys have any questions, any lingering questions, please feel free to write in on our podcast because we are always here for you, fertility, pregnancy, and baby loss survivors. Until next time, thank you so much.